Interventional Spine, located in Irvine, California, is a medical device company that designs, develops, and markets percutaneous devices for the spine that provide benefits to patients, surgeons, hospitals, and payers. Today, we are going to demonstrate the posterior lumbar stabilization system, or PLS procedure. Interventional Spine has made it possible for surgeons to perform posterior lumbar stabilization in order to achieve lumbar fusion via the PERCUTANEOUS system at single or multiple levels without cumbersome rod and screw technology. The PERCUTANEOUS system facilitates the placement of a bone lock implant in the transfacet pedicular position via percutaneous implantation when used in conjunction with the teleport tissue retractor. A series of lateral and AP fluoroscopy images are used to target the appropriate spinal level, the start point on the facet, the trajectory of the implant that is to be placed, and the entry point on the patient's skin. The AP view should be adjusted for the lordosis of the lumbar level which is being treated. This is done by keeping the end plates of the disc level to be treated parallel to each other and should appear as a line. A helpful technique with finding the start point on the facet is to use a K-wire and a marking pin on the skin and identify the following: the midline of the spine, the inferior end plate of the superior body of the level that is being treated, and the medial edge of a line drawn between the pedicle above and below. From the AP view, the cephalad caudal start point is located using the transition of the pars and inferior articular process. Furthermore, this point should be in line with the inferior end plate of the superior vertebral body of the disc level being treated. The medial lateral start point is the medial edge of a line drawn between the pedicles above and below. One technique to help see the proper trajectory is to place a K-wire near or on the patient while the lateral fluoroscopy images are being taken. Adjusting the position of the wire will determine the best trajectory. This information is used to determine the entry point on the patient's skin and start point on the facet. Typically, the entry point will be at the spinous process of the vertebral body, 1 or 2 levels above the level to be treated, such as L3 for a L5-S1. A small midline stab incision is made to accommodate the access needle. The access needle is inserted, with the bevel facing up through the skin along the proper trajectory until the tip is at the start point on the bony anatomy. A series of AP and lateral views may be needed to confirm precise positioning. Once the start point and trajectory are confirmed in the lateral view, the access needle is tapped into the bone. The surgeon may decide to verify placement and trajectory with an AP fluoroscopy image. Once position and trajectory are confirmed, the center stylet is removed. With the inner stylet removed, the .062 K-wire is passed through the access needle and driven across the facet joint through the center of the pedicle to mid-portion of the interior vertebral body. This should be accompanied by a series of fluoroscopy images to ensure the K-wire tip reaches the appropriate position and that the trajectory does not change as the wire goes across the facet joint into the center of the pedicle. To assure precise wire placement, confirmation should be assured through an AP fluoroscopy view. The access needle is then removed while maintaining wire placement. Once the K-wire has been placed, make a 15 mm incision through skin and fascia. The fascia needs to be incised inferiorly to the skin incision to accommodate the teleport tissue retractor. The teleport is placed over the K-wire and advanced until the first tissue retractor comes in contact with the inferior facet. This should be confirmed in the lateral view. Pull the first button of the teleport, then apply forward pressure to advance the second tissue retractor down to the facet. Pull the second button of the teleport, then apply forward pressure to advance the third retractor down to the facet. Use a lateral fluoroscopic image to verify proper placement of the teleport. After confirmation of the final placement of the outer dilator of the teleport tissue retractor, hold the flat distal handle in place. Remove the proximal handle. The first and second dilator will come out and remain as one unit. The cannulated 2-in-1 drill is connected to a cannulated power drill with an AO-style quick connect or Jacobs chuck adapter and passed over the K-wire down to the facet. During drilling, intermediate fluoroscopy images are taken to ensure that the K-wire is not advancing. The drill is advanced under power until the depth-limiting feature contacts the bone. This is confirmed through fluoroscopy. The fluoroscopy image is saved and flipped to the second fluoroscopy screen. The tip of the drill is 30 mm from the sphere. This image can be used as a reference for gauging the depth of the tap and placement of the bone lock implant. The cannulated tap is advanced by hand into the bone until the tip reaches the appropriate depth, which is determined and verified by fluoroscopy. Once the appropriate depth is achieved, the tap is removed. The 4.5 mm bone lock PLS implant is loaded onto the driver, and care is taken not to remove the plastic clip until the implant is placed over the K-wire. Once the implant is over the K-wire, the anti-compression clip is then removed, either by hand or using forceps. And the device is advanced to and then into the bone. The placement of the implant should be with a continuous forward clockwise motion, using a series of fluoroscopy images to ensure proper depth. Do not pull back on the driver when inserting the implant. This may disengage the implant from the driver, which could cause the premature advancement of the compression collar of the implant. The 4.5 mm bone lock PLS implant is inserted until the distal tip is at the desired location, leaving the proximal head of the implant slightly proud to allow for compression. After the proper position of the distal tip has been established, the driver is removed by pulling straight back. The compression tool is passed over the K-wire and onto the pull pin. The device is designed to compress a maximum of 10 mm, but the actual amount of compression needed is determined by the patient's anatomy and the surgeon's preference. Using only one hand to compress, the surgeon can tell when the implant is properly positioned under fluoro by watching the self-retaining washer tilt and lay flat against the bone, indicating that the device is inserted all the way. Once the surgeon is satisfied with the compression, release the handle and pull straight back on the compression tool while paying close attention to maintain wire placement. Once the appropriate compression has been achieved, the pull pin must be removed. The pull pin remover is placed over the K-wire and down to the device. The pull pin remover is turned clockwise while applying light downward force. Typically, it will take no more than 4 full turns for the threads to release, at which point the surgeon will hear and/or feel a clicking that will indicate that the pull pin has disengaged from the implant. At this point, the pull pin remover can be removed from the site, making sure to verify that the pull pin is still engaged with the pull pin remover. Final images are taken. The guide wire is removed, followed by the removal of the teleport tissue retractor. Final images of the bone lock implant in lateral and AP views. Utilizing the same midline 15 mm incision, the contralateral side is fixated using the PERCUTANEOUS system. Lateral and AP views of multi-level fixation utilizing the same 15 mm midline incision with the PERCUTANEOUS system. In summary, we believe the PERCUTANEOUS system allows surgeons the least invasive means to provide posterior lumbar stabilization in the market today. This means less trauma and pain for the patient while providing comparable fixation of the spine as compared to more invasive rod and screw technology.